Hello, I'm Maria, and today I want to share something with you that could fundamentally change how you understand and manage your blood sugar, especially if you're living with diabetes. This video is my detailed summary of important research and clinical observations about a phenomenon that affects millions of people over 60, yet rarely gets the explanation it deserves. If you've ever gone to bed with acceptable blood sugar only to wake up with it significantly higher despite not eating anything overnight, then what I'm about to share could be exactly what you've been searching for. Please stay with me through this entire video, because understanding what happens to your blood sugar while you sleep isn't just interesting information. It could help protect your kidneys, your eyes, your nerves, and your overall health for years to come. This knowledge could make the difference between feeling defeated every morning or feeling informed and empowered. Before we begin, I need to share an important disclaimer. Everything I discuss today is strictly for educational purposes and should not be considered personal medical advice. I cannot provide individualized medical guidance through this video. Please never stop, start, or change any diabetes medication without first consulting with your healthcare provider. Never adjust insulin doses on your own, as this can be extremely dangerous. Always work closely with your doctor or endocrinologist for all decisions about your diabetes management. Let me tell you about Margaret, because her story will probably sound very familiar to many of you. Margaret was 68 years old when I first met her. She'd been living with type 2 diabetes for 12 years. 12 years of checking her blood sugar multiple times every day. 12 years of taking her prescribed medications faithfully. She was doing everything her doctor told her to do. She attended all her appointments. She tried to eat carefully. She was compliant with her treatment plan. Margaret was especially diligent about checking her blood sugar every single morning. Before she even got out of bed, she'd reach for her glucose meter on the nightstand. And every morning, the number staring back at her was devastating. 168, 174, 182, sometimes even higher. Her fasting morning blood sugar was supposed to be under 130, ideally under 100. But Margaret's was consistently in the 160s and 70s, sometimes pushing close to 200 every single morning without exception. But here's what confused and frustrated her so deeply. She was extremely careful about what she ate for dinner. She'd measure her portions carefully. A palm-sized portion of lean protein, grilled chicken or baked fish, a large serving of non-starchy vegetables, maybe a very small amount of brown rice. Nothing excessive. No dessert, no sweets, no nighttime snacking whatsoever. She'd finish dinner by 6:30 or 7 in the evening and wouldn't eat anything else, not a single bite, until breakfast the next morning. She'd check her blood sugar at bedtime, around 10 at night, before taking her evening medication. And the reading would be reasonable, acceptable even. 138, 142, 135. Not perfect, but under 150. Her doctor had told her that anything under 150 at bedtime was acceptable. So Margaret would go to sleep thinking everything was under control. Her bedtime blood sugar was in an acceptable range. She hadn't eaten anything after dinner. She was taking her medications as prescribed. There was absolutely no reason for her blood sugar to rise overnight. But every single morning, without fail, she'd wake up to find her blood sugar 30, 40, 50, sometimes even 60 points higher than it had been when she went to bed 8 hours earlier. She'd gone from 140 at bedtime to 185 in the morning while she was sleeping, while she was lying in bed doing absolutely nothing. How could this possibly be happening? Where was this extra glucose coming from? She wasn't eating, she wasn't consuming anything, she was just sleeping. Margaret asked her doctor about this repeatedly over several years. At every 3-month follow-up appointment, she'd bring up the same concern. "Doctor, I don't understand. My blood sugar at bedtime is okay, but every morning it's so high. I'm not eating anything overnight. What's happening?" Her doctor's response was essentially the same every time. "Your diabetes is progressing. We need to add more medication." But Margaret was already experiencing side effects from her current medications. The idea of adding more, especially insulin with its risk of severe low blood sugar episodes, terrified her. She felt like she was doing everything right and still failing. She felt like her body was betraying her. Every single morning when she saw those elevated numbers, she felt defeated, frustrated, angry, and scared. She knew what those numbers meant for her future. She'd read about diabetic complications. She understood how chronically elevated blood sugar damages the eyes, the kidneys, the nerves. Her aunt had lost her vision completely from diabetic retinopathy. Her father had lost his leg to diabetes. Margaret was terrified of that happening to her. When Margaret came to see me, she was desperate for answers, desperate for someone to actually explain what was happening instead of just telling her she needed more medication. "Why is my blood sugar going up overnight?" she asked me, and I could hear the frustration and fear in her voice. "I'm not eating anything. Where is that extra glucose coming from? What am I doing wrong?" I looked at her blood sugar logs, months and months of readings meticulously documented. I saw the pattern immediately. Bedtime readings in the 130s and 140s, morning readings in the 170s and 180s. Consistent elevation overnight. "Margaret," I said, "you're not doing anything wrong. Your blood sugar is rising overnight because of specific physiological processes happening in your body while you sleep. But nobody's explained this to you properly, and more importantly, nobody's given you a framework for understanding it." Margaret's eyes filled with tears. "You mean it's not my fault?" "Yes," I told her. "But you need to understand the mechanisms first, because there are actually several different reasons blood sugar can rise overnight, and the approach depends on which mechanism is affecting you." Over the next 6 months, working closely with her endocrinologist, we systematically identified Margaret's specific causes, and her doctor adjusted her treatment accordingly. Her morning fasting blood sugar dropped from averaging 178 down to averaging 132. Still not perfect, but a dramatic 46-point improvement. She felt hopeful for the first time in years. But I'm not going to tell you what specific changes her doctor made yet. You need to understand the underlying physiology first. You need to understand why overnight blood sugar elevation happens at all, because there are actually multiple distinct mechanisms. So let me ask you, have you experienced this frustrating phenomenon? If you've gone to bed with acceptable blood sugar and woken up with it significantly higher, please leave a comment below. I want to understand how many people are dealing with this invisible problem. Now let me explain the physiological mechanisms, because understanding these is absolutely essential. The first and most common mechanism is called the dawn phenomenon, also sometimes called the dawn effect. This affects the majority of people with diabetes to varying degrees. The dawn phenomenon is driven by normal hormone rhythms that occur in every human being, diabetic or not, every single night. Here's what happens. In the early morning hours, typically between 4 and 8 in the morning, your body begins its natural wake-up process, even before you're consciously awake. Your brain signals your adrenal glands, which begin releasing higher levels of cortisol. Cortisol is your primary stress hormone, but it's also your wake-up hormone. Levels are lowest around midnight to 2 in the morning, then begin rising sharply in the pre-dawn hours, typically peaking around 7 or 8 in the morning. But cortisol has metabolic effects beyond just wakefulness. Cortisol opposes the action of insulin. It signals your liver to break down stored glycogen and convert it into glucose. It tells your liver to create new glucose from other sources. Essentially, cortisol is telling your body, we're about to wake up. We need energy. Release glucose into the bloodstream. In addition to cortisol, your body releases other hormones during these pre-dawn hours. Growth hormone, epinephrine, norepinephrine. All of these promote glucose release from your liver. In a person without diabetes, with a normally functioning pancreas, this early morning glucose release is perfectly matched by appropriate insulin secretion. The pancreas senses the rising glucose and secretes precisely the right amount of insulin. Blood glucose remains stable. But in a person with diabetes who has insulin resistance or impaired pancreatic function, this delicate balance is disrupted. Your liver releases glucose into your bloodstream in response to the cortisol surge, but your body either can't produce enough insulin to match this glucose load, or your tissues don't respond properly to the insulin that's present. That glucose accumulates in your bloodstream. Blood glucose concentration rises, sometimes dramatically. This is the dawn phenomenon. Your blood sugar rises in the early morning hours, driven by normal hormone rhythms that your diabetic metabolism cannot properly compensate for. You might go to bed with blood glucose at 140. At 2 in the morning, it might still be around 140. But between 4 and 7 in the morning, your liver is actively releasing glucose into your bloodstream, and your body can't handle it appropriately. By the time you wake up at 7 and check your blood sugar, it's 180 or 190. The dawn phenomenon can raise blood glucose anywhere from 20 to 100 points during those early morning hours, depending on various individual factors. And there's nothing you consciously did to cause it. You didn't eat anything. It's your body's normal hormonal rhythms interacting with your diabetic condition. But here's what many people don't realize. The dawn phenomenon isn't just affecting your single morning reading. It's affecting your entire day's blood sugar control. When you start your day with blood glucose at 180 instead of 110, everything downstream is elevated too. Your whole day's glucose levels are shifted upward because you began the day elevated. This means more time spent with high blood sugar, more variability, more cumulative exposure to elevated glucose, more potential for damage accumulating over time. The second mechanism, which is less common but extremely important to recognize, is called the Somogyi effect, named after the doctor who first described it. This has completely different underlying causes and requires a completely opposite approach. Getting this wrong can be dangerous. Here's what happens with the Somogyi effect. Your blood glucose drops too low during the night, typically between midnight and 3 in the morning, often into the dangerously low range, below 70, sometimes even into the 50s or 40s. This nighttime low blood sugar can occur for various reasons. Perhaps your evening medication dose is too high. Perhaps you took your usual dose, but ate less dinner than usual. Perhaps you exercised in the evening and your muscles are still pulling glucose from your bloodstream hours later. When your blood glucose drops into this low range, your body perceives this as a serious emergency, and rightly so. Your brain requires a constant supply of glucose to function. If blood glucose drops too low, you can lose consciousness, have seizures, or suffer permanent harm. Your body is programmed to prevent this at all costs. So when blood glucose drops too low, your body initiates a powerful response. Your adrenal glands rapidly release epinephrine, also called adrenaline. This is your fight-or-flight hormone. Epinephrine signals your liver to immediately release glucose. Your adrenal glands also release cortisol. Your pancreas releases glucagon. All of these hormones work together to raise your blood glucose back up to safe levels. The problem is that this response often overshoots dramatically. The goal is to bring blood glucose back to normal, maybe 90 or 100. But the response is so aggressive that blood glucose doesn't just return to normal, it shoots way up, often into the 150s, 160s, 170s, or even higher. This is the rebound. And here's the truly challenging aspect. You sleep through all of this. Most people don't wake up when their blood glucose drops to 60 at 2 in the morning. They don't feel the adrenaline surge. They sleep through the entire event. They wake up at 7, check their blood glucose, and it's 185. They think, my blood sugar is high again. But what actually happened is that their blood glucose went dangerously low overnight, their body launched a massive response, and they're seeing the aftermath of that rebound. The Somogyi effect is particularly problematic because it's often caused by the treatment itself. Your doctor sees your elevated morning readings and thinks, we need better control, let's increase the evening medication. So your bedtime insulin gets increased. But this higher dose makes you more likely to experience nighttime low blood sugar. The low triggers an even bigger rebound. Your morning readings paradoxically get worse instead of better. The doctor sees the worsening morning readings and increases medications further. The cycle continues, potentially leading to severe and dangerous situations. This is why it's absolutely critical to distinguish between the dawn phenomenon and the Somogyi effect. They present similarly with elevated morning readings, but the underlying mechanisms are completely opposite, and the approaches are opposite as well. Treating the dawn phenomenon often involves adjusting medication to provide better overnight control. But treating the Somogyi effect requires reducing medication to prevent the nighttime lows that trigger the rebound. Let me tell you about Robert to illustrate why identification is so critical. Robert was 71 years old with type 2 diabetes for 18 years. His morning fasting blood glucose was consistently elevated, averaging 174. His doctor kept increasing his bedtime insulin dose, thinking more insulin would bring that morning number down. But something strange was happening. Robert's morning blood glucose kept getting higher, not lower, as his insulin dose increased. At 12 units of bedtime insulin, his average morning glucose was 174. His doctor increased the dose to 16 units. Over the next 2 weeks, Robert's average morning glucose rose to 181. The doctor raised the dose to 20 units. Robert's average morning glucose went up to 187. More insulin was making things worse, not better. This made no sense. Insulin should lower glucose. But nobody stopped to ask the critical question: what's actually happening overnight? When we finally had Robert check his blood glucose in the middle of the night at 3 in the morning, the truth became immediately clear. His bedtime glucose at 10 was 145. His 3 a.m. glucose was 52, severely low. His morning glucose at 7 was 187. The pattern was unmistakable. Robert was experiencing the Somogyi effect. His insulin dose was causing dangerous nighttime lows around 2 or 3 in the morning. His body was launching a massive response. By morning, his glucose had rebounded into the 180s. Every time his doctor increased his bedtime insulin, he made the nighttime lows worse, which made the rebound worse, which made the morning numbers worse. They were treating the problem with more of what was causing the problem. Once we recognized the Somogyi effect, the solution became clear. Robert worked with his endocrinologist to reduce his bedtime insulin dose. They had him check his 3 a.m. glucose several more times to ensure he wasn't going low overnight. At a lower dose, his 3 a.m. glucose was 102, safe, and his morning glucose improved to an average of 143. Still not perfect, but 44 points better than it had been on the higher insulin dose. He was safer, and his control was actually better on less medication. This is why identification is absolutely critical before attempting any intervention. The third mechanism involves late evening food consumption or meals that cause prolonged glucose absorption extending through the night. When you eat carbohydrates, they must be digested and absorbed. This process doesn't happen instantly. Simple carbohydrates are absorbed relatively quickly, but complex carbohydrates, especially when consumed as part of a meal containing protein, fat, and fiber, can cause prolonged glucose absorption. If you eat a large dinner at 8 in the evening and then go to bed at 10, your body is still actively digesting and absorbing those carbohydrates while you sleep. The glucose from your dinner continues appearing in your bloodstream for hours after you've fallen asleep. Many people check their blood glucose at bedtime, see a number in an acceptable range, and assume their glucose is controlled for the night. But they're checking before their blood glucose has peaked from dinner. The fourth mechanism involves medication-related issues, particularly timing and duration of action. Different diabetes medications work through different mechanisms and have different durations. If your medications aren't properly timed to provide adequate coverage during the overnight hours, glucose control during this period will be inadequate. The fifth mechanism involves sleep quality and sleep disorders, particularly obstructive sleep apnea. Poor sleep quality and sleep disorders can significantly impact overnight glucose control through multiple pathways. Sleep apnea deserves special attention. In this condition, breathing repeatedly stops during sleep, sometimes hundreds of times per night. Each time breathing stops, oxygen levels drop. Each event triggers a stress response, a burst of hormones. These repeated stress responses have profound metabolic effects. Each event causes release of cortisol, epinephrine, and other hormones that stimulate glucose release. Over the course of a night with hundreds of these events, glucose can rise substantially. People with untreated sleep apnea often have substantial overnight glucose elevation that they cannot explain through diet or medication factors. So you have 5 distinct mechanisms that can cause overnight blood glucose elevation: the dawn phenomenon, the Somogyi effect, late evening food consumption, medication timing issues, and poor sleep quality or sleep apnea. Most people with problematic overnight glucose elevation have more than one of these mechanisms operating simultaneously. But the critical next step is identification. You need to know which mechanism is affecting you specifically, because the approach depends entirely on which mechanism is operating. The fundamental principle is this: you cannot identify what you don't measure. You need data. You need to understand what your glucose is actually doing throughout the overnight period. The monitoring protocol I recommend discussing with your doctor is this. For 1 week, check your blood glucose at 3 specific times. First, at your usual bedtime, typically around 10 at night. Second, in the middle of the night at approximately 3 in the morning. Yes, this requires setting an alarm and waking yourself up specifically to check. It's disruptive, but it's essential, and it's only for 1 week. Third, at your usual wake time in the morning. These 3 data points, measured over several nights, will reveal the pattern and tell you which mechanism is operating. If your bedtime glucose is around 135, your 3 a.m. glucose is around 140, and your morning glucose is around 175. That's the classic pattern of the dawn phenomenon. Your glucose is stable through most of the night, but rises significantly in the early morning hours. If your bedtime glucose is around 135, your 3 a.m. glucose is around 60, and your morning glucose is around 175, that's the pattern of the Somogyi effect. You're dropping low in the middle of the night, then rebounding. If your bedtime glucose is around 135, your 3 a.m. glucose is around 165, and your morning glucose is around 160. This suggests prolonged glucose absorption from your evening meal. These patterns give you and your healthcare team critical information about what's actually happening, which then guides what discussions to have. Now, let me briefly explain what types of approaches your doctor might consider for each mechanism. Remember, I'm providing educational information, not telling you to do any of these things. All decisions must be made by your physician. For the dawn phenomenon, there are several potential strategies your doctor might consider. One approach is adjusting the timing of existing medications. If you take metformin twice daily, taking the second dose at bedtime instead of at dinner might provide better overnight coverage. Another approach involves adjusting or adding medication specifically to cover the dawn period. Some patients benefit from adjustments to basal insulin timing or dosing. Some benefit from adding or adjusting other diabetes medications. For lifestyle approaches that can complement medical management, some evidence suggests that evening exercise, perhaps a 20 to 30-minute walk after dinner, can improve insulin sensitivity for 12 to 16 hours afterward, extending through the night. For the Somogyi effect, the primary approach is preventing the nighttime lows that trigger the rebound. This often involves working with your doctor to reduce evening medication doses. Some patients genuinely do need a small bedtime snack to prevent overnight lows, but this should only be done based on actual monitoring data showing nighttime lows, not as a general practice. For late eating or large evening meals, the discussion centers on dinner timing and composition. Eating dinner earlier when possible, keeping carbohydrate portions controlled, emphasizing protein and non-starchy vegetables can all help. For sleep apnea, this requires addressing the underlying sleep disorder. If you snore loudly, wake up gasping, or feel unrefreshed despite adequate time in bed, discussing sleep apnea evaluation with your doctor is important. Treatment of sleep apnea can significantly improve overnight glucose control in people who have both conditions. Let me return to Margaret. Her monitoring revealed a clear dawn phenomenon pattern. Her bedtime glucose averaged 138. Her 3 a.m. glucose averaged 142. Her morning glucose averaged 178. Working with her endocrinologist, they made several adjustments. They switched her metformin to extended release and moved 1 dose to bedtime. They adjusted her meal timing. She added evening walks after dinner. These changes dropped her average morning fasting glucose from 178 to 132 over about 3 months. A substantial 46-point improvement that made her feel empowered and hopeful. Today we've covered the complex physiology of overnight glucose elevation. You've learned about the dawn phenomenon, the Somogyi effect, late eating, medication timing issues, and sleep disorders. You've learned that these different mechanisms require different approaches, which is why identification through monitoring is so critical. My message isn't to adjust your medications yourself. These are complex processes that require professional medical management. My message is empowerment through understanding. You now comprehend what might be happening inside your body overnight. You know what monitoring data to gather, you know what patterns to look for, you know what questions to ask your doctor. Implement the monitoring protocol I described. 1 week of checking at bedtime, 3 a.m., and morning. Gather the data. Look for the patterns. Then schedule an appointment specifically to discuss these findings with your endocrinologist or primary care physician. Show them the data. Ask what options might be appropriate for your situation. I hope this video has been genuinely helpful for you. If you found value in this information, I would greatly appreciate it if you would take a moment to like this video and subscribe to my channel. And please, I encourage you to leave your questions and comments below. Do you struggle with elevated morning blood sugar? Have you done overnight monitoring? What patterns are you seeing? I read every comment and do my best to respond to your questions. Your experiences and your feedback help me create even more useful content for our community going forward. Thank you so much for spending this time with me today. Take care of yourself. Gather the monitoring data this week. Schedule that discussion with your doctor. Work in partnership with your healthcare team. I'll see you in the next video. Until then, take good care.